previous session. This is an incredible panel of experts to ask it now. So with that, I will hand it over. Oh,
it's working. Yeah. Is that what you, no?
Yeah.
This is working too.
Yeah. Good deal. All right. Now that we've had our mic check, I'll hand it over to our first set of introductions. If you guys will just give a brief introduction. I know people probably know who you are from today, but it's always nice to have the background.
Sure, I'll start things off. So I'm Senthil Sukumar. I'm at Baylor College of Medicine in Houston, Texas, and I can take care of adult hematology patients, and I have a clear interest in TTP.
Oh, hi, I'm Marie Scully. I'm from the UK. I work at a hospital called University College in London. I am the clinical lead for TTP nationally in England, as we're broken up with Scotland and Wales. They're not included in our healthcare, but they follow what we do. But we do have the UK registry, which does include all of the devolved nations. And thank you very much for the invitation.
I'm Spiro Cataland. I'm a hematologist from Ohio State University in Columbus, Ohio, and have been doing this TTP thing for quite a number of years, about 20 years, with many people here. So it's a pleasure to be here and help answer any questions we might be able to help with.
All right. With that, I'm going to start our first question from online.
A long time.
So frequently you see TTP or AHUS misdiagnosed as preeclampsia health. And if you see this frequently, what labs or clinical findings might be better indicative of TTP or AHUS rather than health or preeclampsia? So straight into the pregnancy question there.
That's me, I presume, because you're both staring at me. So firstly, preeclampsia and HELP are way more common than TTP or HUS. So misdiagnosis is probably not necessarily the situation. I would turn it around that people consider, or obstetricians, hematologists consider other TMAs when preeclampsia and HELP don't fit the pattern, and they do have a pattern. So firstly, getting preeclampsia or HELP around 20 weeks. You don't get it before 20 weeks. So very early on, it's worth considering if it's another TMA. Secondly, if you've delivered baby and the platelet count is still dropping after about 48, 72 hours, then it's important that TTP is considered. With HUS, it's slightly different. The majority of cases present in the postpartum period, and the kidneys just deteriorate very, very quickly, much more than in TTP. So it's usually more obvious. Bringing it back a further bit, TTP and HUS are the only two conditions that will present in the first trimester of pregnancy and the second trimester of pregnancy. But a bit like preeclampsia, they're common in the third and postpartum period. If you have TTP, and I'm going to concentrate obviously more on that, you often also have preeclampsia. So it's almost ubiquitous, actually. So it's having that level of suspicion if the platelet counts are lower than one would expect, or the course is not going the way one would anticipate with preeclampsia. So some ladies can have terrible preeclampsia, but it does not mean they've got TTP. And it's very rare to have TTP in pregnancy. So we get ADAMTS13 testing very easily in the UK, which is not the situation necessarily over here in all institutions. But if we see the platelet count less than 50,000 and the blood film features, and we look at another parameter called LDH, lactate dehydrogenase, which should not be increased in pregnancy, we will run an ADAMTS13 activity level pretty easily. We run them daily. We just add it on to the next run or get it done urgently. But most of it, to be honest, is not easy in pregnancy, but having a level of suspicion. So rather than misdiagnosis, because it's not a common diagnosis, it's about 1 in 200,000 and probably even less common than that of ladies with preeclampsia will have TTP. What have I missed?
You're doing good. I think the general rules to think about is TTP in general, these are not absolute, is going to be in the second, third trimester. In general, AHUS will show up postpartum. Doesn't have to be that way. But as Marie said, we also use the platelet count and the creatinine. And in general, in TTP, it's a lower platelet count. In AHUS and other TMAs, the kidney injury is worse in general. And it, like Maria said, these are difficult things to diagnose. The problems and the errors physicians make, I think, are not so much on their first hypothesis. That's logical. Sometimes physicians have a hard time getting off their first idea because everybody likes to be right. They don't want to be wrong. The mistake you make is saying, oh, I get this, but this is just an atypical presentation of this. Oh, but this case is different. I think the idea is you need to look back, you get your first bit of evidence back and said, the renal failure is worse than I thought. Maybe this isn't TTP. So that's, I think, where physicians have to look back at their first idea and see if it makes sense. And if not, be willing to change your idea and your treatment plan.
And I think the only thing I would add is, you know, as a patient or, you know, a family member or caregiver, if something feels a little bit off, don't hesitate to just sort of advocate for your OBGYN to consult the hematologist a little bit earlier too. You know, because they may be like, oh, no, this is HELP or this is preeclampsia. And they're kind of, like Spiro was saying, they're sort of set on it. But don't be afraid to just be like, well, can you have the hematology team come by anyway? Because they may recognize some of these more subtle features of, is it more neurological or, you know, renally involved than we would think it would be for these other conditions.
Everybody looks at things through their own glass. An obstetrician sees it through their world. A hematologist sees it through their world where they see more TTP. Pediatric versus adult pediatricians see more AHUS than TTP. And it's kind of maybe similar in adults, but you'll see that sort of paradox. Doctors sort of see what they see, I guess, is the way of putting it.
Good question. Any more?
Being treated, you know, for TTP pregnancy, if I start developing preeclampsia, what is the treatment?
Have you got immune or a congenital immune? Okay. So the treatment of preeclampsia is the treatment of preeclampsia for any lady. There's nothing extra or specific. The more important thing is to ensure that the TTP routine bloods are within the normal parameter and to monitor the ADAMTS13 during pregnancy. So the treatment for preeclampsia won't change, but if there was a TTP element to it, that's where the difference would be. Go.
Right.
Please correct me if I'm wrong, but in your presentation, you mentioned we have a higher risk of diabetes, stroke, cardiovascular disease. So what is your recommendation to, as a financial plan, these things? Like, should we be getting frequent MRIs? How often? What is your recommendation on that?
It's a good question. So I think that with regards to being at, I'm just reframing the question too, is for the folks on Zoom, but being at, you know, higher risks for some of these other cardiovascular disease risk factors is basically the question. And we don't have enough data yet to say that we need to be doing more screening MRIs and things like that. We may have that in a few short years. But in terms of the modifiable risk factors that we know are associated with these problems, we should try to be as aggressive about as we can be. There are a lot of medicines for high blood pressure, high cholesterol, you know, elevated sugar. And so being a little bit more aggressive than we normally would be, you know, someone your age and condition otherwise, right, for example, is probably the best tools we have at the moment.
I think the last 5 to 6 years, I find myself looking at those kind of modifiable factors more than anything else in our patients, looking more carefully at the blood pressure than we did 10 years ago. Smoking and things like that. We still obviously worry about the ADAMTS13 activity and predicting the risk of relapse. But I think we're a lot more cognizant of these complications. And as we are now doing studies to understand how common these things are and why they happen, because if you know why they happen, you might be able to prevent them. And we're focusing on doing what we know might help. Senthil and I have been working with our cardiologist on a project looking at heart issues in patients. And the question has come up over and over again, should I take a baby aspirin? And her answer has always been, I don't know, you might take a baby aspirin. We just don't know what's going to help. So we're not so focused on that. So we want to do things that we know are going to help, but not just throw things at people because that's what everybody else does with heart issues.
Follow up, like with the physician or the hematologist, or the attending hematologist, like who should be checking up on your blood pressure?
Yeah, that's a great question. The way that I've approached it. Oh, yeah. So the question was, who should be monitoring for some of these modifiable risk factors, the patient's family physician or their hematologist? I think the way that I've approached this is by finding kind of an ally within our general medicine or family practice departments who, we tend to send more of our TTP patients to for their ongoing primary care. But then also with relaying the message through my communications with them that, oh, hey, I know this is a young female patient who's at a normal weight and not obese, et cetera, but her systolic blood pressure is a little bit on the higher side. I think even though we'd recommend just lifestyle modification, if it doesn't get better in a short time period with that, I think you should start them on a blood pressure medicine even earlier than maybe a traditional guideline might. Basically, treat this person as though they're a diabetic or some other cardiovascular disease equivalent that we kind of already know about and would be more aggressive about in other situations. So that's how I tend to approach it.
Would you say that sometimes, unfortunately, insurance dictates who's going to make those choices?
Not as much for these sort of more basic issues. I mean, I agree with what Senthil said. I think it's everybody's responsibility, but I think it's the hematologist who understands that that it's not, you're not just a 40-year-old woman or man, but you had a history of TTP, and this might be more of an issue. It's the hematologist's responsibility to let your cardiologist know, the nephrologist know, to be a bit more careful with this issue. And we, like Senthil said, we have our own cadre of physicians. That I've got a cardiologist we work with, a psychiatrist who's very good, a nephrologist who's very good, and a neurologist who we go to. So they're already in tune to the issue. So there's no introduction need. They just sort of get right to the issue and know it's a unique it's not just a 40-year-old man or woman.
Fortunately, most blood pressure, cholesterol meds, things like that are readily available at cheaper costs compared to some of the other types of treatments we do. So hopefully insurance won't be too much of a barrier, but it's a problem in the US for sure.
So this is a question kind of like that one, but it's more like if you had a transplant and then you feel like something is off, do I come to you first or transplant first? I'm kind of stuck in between the two. And I know you're not transplant doctor. It's just.
What kind of transplant? Kidney transplant?
Yeah.
I mean, I think, if it's recent to the transplant, the first port of call should be the primary physician looking after that side of things. And they can very quickly move you to, once they know that's okay, move you to other subspecialties as required. You don't look after kidney transplants, I hope.
No, not regularly, no.
Good.
No, but I think sometimes you have a connection with the nephrologist or the hematologist that's taking care of you for whether it's TTP or AHUS. And that's important, but you still have to do the right things common sense wise for medicine. So when you get chest pain, you might inform your hematologist, but you ought to go to the ER and get that checked out, or talk to your cardiologist if you have a history. By the same token, you've got to make sure that transplant docs know about it first, with us in the loop with them, so we can all discuss it together. Because again, just like the other issues, there's some subtleties that go along with that diagnosis and the transplant. Yes.
So in terms of, I know at one point it was discouraged, but if a person is in a stage where their blood counts are so low that they need this in order to even get this extra line or to what are your rules in terms of, is there flexibility in giving platelets?
I'll repeat the, so the question is platelets, what's the role? Are they ever needed? Should they ever be given? Can they ever be given? Is that a good summary?
No. My flat answer is no, they should not be given. There would be no need to give a pool of platelets to put in a central line, even those big lines. There's absolutely no rationale in any hospital where the anaesthetic team, or I don't know how you do it, what you call them over here, but there is no rationale in this era. That was different, and part of that again is all part of education. It would be unusual to have significant GI bleeding when you come in with acute TTP. I mean, sometimes you can have bad bleeding, bad PV bleeding, but in fact, getting the platelets up with the current therapies is the correct mode of action in you support patients. Otherwise, I have never given a pool of platelets to a TTP patient. That said, if they were in extremis, I would do it on the back of a plasma exchange. If you give platelets, and we have seen patients that have had platelets before the diagnosis has been considered and sent for treatment, the outcome is very poor. They have multi-organ thrombosis already, and it absolutely fuels the fire. There are other ways of dealing with bleeding, and for ladies, the most common obviously is PV bleeding at the time of presentation. There are other methods of improving that, but also the quickness of treating patients these days. It's not like it was 5 or 10 years ago. The platelets go up much quicker, and those symptoms can resolve very, very quickly. But, you know, it does depend on the situation. Have you given platelets?
No, you don't need platelets. There's two situations where they are given. You'll see it here in the US. One is when someone is not thinking of why, they're just seeing a number and giving platelets, and they're not thinking about why. And in that case, it's an advertisement that they may not be on the right diagnosis. So you're kind of advertising, I may have missed the boat here. The other situation is when we have surgeons who put lines in who rarely will tell us, I won't do it, the platelet count's 10. There's a little bit of education that has to happen that tells them a patient with TTP and a leukemia patient, both with a number 10, are two different animals. Leukemia 10 is not making platelets. TTP is making a ton of platelets. They're just being consumed. And that's why we don't see, it sounds funny, but bleeding, despite that low platelet count, is not a big issue. And that's why when we started out with some of these new therapies, when they were first getting going, something that blocked platelet function was not a worry. I think because we understood this is a clotting disease. Even at a platelet count of 10, it's a clotting disease. And when people die from it, they die from clotting, not bleeding issues. Typically, there are rare instances, but clotting is the problem. So platelets are rarely required.
Is there any role in this case of FFP plasma, those patients, instead of platelets?
Repeat the question, please.
The role of FFP instead of platelets in this situation?
When the platelets are really low and there's a concern of bleeding from, management and intra-hospital management, is there a role for FFP?
Into hospitals when you're
Yes.
being, oh yeah, no, that's.
To avoid bleeding because of the, some people, some surgeons or anesthesiologists don't want to get the central line.
Yeah, so I think, the role of FFP in this situation is mainly the way that we've been utilizing it is when somebody is at, a smaller or more remote area and they need to come to like a tertiary center, like closer to, a larger city or what have you. Well, absolutely, that takes hours, right? That process inherently just takes hours. And so you don't want to just sit there and do nothing. And so in that situation, before they put a line in or get anything else going, we'll say, please give them, FFP or fresh frozen plasma so that they have at least some infusion of plasma before they make it. And then just to kind of earlier the point about platelets, I think all of us at our centers and most of the centers, here in the USTMA, the procedure teams, whether there be the ICU or the surgeons or anesthesiologists or whoever, can and do routinely place the plasma exchange, larger bore catheters in single-digit platelet counts without, massive hematomas or problems historically in basically all of our patients. And so we're really comfortable just sort of, even if they're a little bit hesitant, kind of poking them to just do that because, folks do well.
If you think about it simply, is giving plasma before a line or platelets going to help? No. Is it going to hurt? Probably no. But what it's going to do is delay putting the line in to get the right treatment started. So when you are waiting for this or waiting for that, they haven't got the IV in. We have a slight delay from the blood bank. And before you know it, it's 6 hours later and the apheresis team is not in. So that's the real problem. It distracts people from what has to be done and it gets delayed. Yes.
The last relapse I had, mentioned it a little bit earlier, but they, doing the plasma exchange, they wanted me to get albumin. I denied because I had never, my first, initial and the first relapse, I had not had that. He had said something about, like, you don't have as much reaction to it. Is that standard now? Is that something to be scared of? Or what is your opinion on that?
I'll repeat the question, let you answer. The question is using, instead of plasma, completely using some albumin, probably a mix is what they said, for your treatment. Right.
Is that me?
You can.
That's just because I'm going to go, no. No. So the whole point of plasma exchange is to deliver ADAMTS13. That it's his primary role. There's no other real role. And it's unfortunate that we've got all the other constituents of plasma, but it's the only thing that we've got that can increment the ADAMTS from very low up to about 50%. Okay, it drops and then we've got that. Albumin is not going to reduce the risk of you having a reaction. If you give, 2 liters of albumin and 3 liters of plasma, it might be in the 3 liters of plasma you have the reaction rather than 5 liters of plasma. You can't dictate which one are going to be problematic, and it's not going to help. It's just going to dilute things. It's not going to replace, and that is the only role of plasma exchange. Now, it may be that there may be not enough plasma in the hospital and they've had to do it. There could be other circumstances. So, but we have
prior reaction, they might want to do that.
But it's not going to deliver. It's not, to give 5 liters, of which 2 liters is albumin.
No, and there's
It's
always
not
these
helpful.
debates of what are we really doing with plasma exchange? Are we adding ADAMTS or removing antibody? It's probably both, but it's more optimal to give plasma. Rare situation with Jehovah's Witnesses where they won't accept blood products, people will try doing albumin exchanges, and you can do a couple before you essentially dilute their blood, and it's more dangerous. So nowadays there's better ways of going at that, but there's no reason to start with albumin and plasma mix. Yeah.
Good for you.
Yeah, the other thing is that, in other areas where they do exchange, they use albumin exclusively. Within 2 days of using pure albumin, you will end up with something called a coagulopathy. So your whole coagulation screen is just abnormal because you've diluted down all the factors that you need to help you in a kind of steady state. So it introduces actually more problems if it's going to be a regular thing.
We're talking about diluting it down a lot. Will you explain what albumin is? Just for my own education, is it a blood product or what is it?
It is a blood product. It's a protein that is primarily used in exchanges where you've got a high viscous state, usually as one-offs, or the more common use for albumin is in patients that have liver failure, where that protein, the albumin, which binds loads of other proteins, is extremely low. So they become very swollen and unwell. Nothing to do with TTP. So, but it will dilute you if you use recurrent plasma exchanges with just pure albumin. It causes its own set of problems.
If you're removing a bit of volume, you've got to replace that volume. You just can't leave them lacking a couple of liters of volume.
What do you mean volume?
Blood volume.
So
When you're taking out patient plasma, you're returning donor plasma.
Plasma volume.
If you take out the plasma and don't replace it with anything, so the albumin is essentially the fluid you're giving with albumin, a protein in it, when you aren't giving plasma. You have to give something back. You can't just remove blood.
bad reactions to fresh frozen plasma. And I had this period of time where I think it was going to help.
Right.
And then I went to solid detergent plasma, and that's all I've ever gotten since. So there was that gap in there. It
Yeah.
sounds like a bad gap.
Well,
Well, it was a
it's not
necessary.
it wouldn't be a gap of choice. Bad is the wrong word because you've got to deal with the situation in front of you. And this is a generic opinion, but you've hit the nail on the head. There is a solvent detergent alternative that is available in the States, for which the risk of reactions is significantly reduced. And it's the only one we use in the UK. We haven't used this standard FFP for nearly 20 years. So the reaction rate is minimal.
Much better. But there's one reason why it's not used in the States very often. Anybody want to guess? It's more expensive.
Yeah.
So you have much less reactions with it, but it's more expensive. So hospitals in general will take the path of least resistance, which is the cheaper choice.
In fact, I think at almost every hospital I've worked or trained at, I don't think it's stocked routinely.
We got 2 freezers full of it in our blood bank.
I was
When we just don't
I was
use
on a
it.
data safety monitoring board of a study of octoplast, and we had nothing to review because nobody was using it. So it was quite boring role. That's I've upset some people at certain companies, but that's the reality. It's just not used.
It's also reason why is because you put it out instead of Canadian Blood Services getting the blood, you put a private company get the blood. They pay for blood work.
I mean, it's the better way to go. It's the better way to go. It's just those are some of the hurdles. Maybe getting rid of plasma exchange altogether may be a better way to go too.
Question at the back. Oh, sorry. I think.
Why do doctors keep you on penicillin when you start Solaris initially and then just never take you off of it? This isn't personal experience, but someone has asked me before and I did not know the answer.
So whenever you're taking, so why do some physicians keep their patients on penicillin when they're on complement blocking agents like Solaris indefinitely? I think it sounds like was your question. So the reason that you have to get all the vaccines and everything, and then sometimes you get antibiotics initially when you start these medications, is because they increase your risk of infection for certain types of organisms, and particularly a certain type of meningitis or Neisseria meningitis. It increases the risk pretty substantially. And so, and originally we would just do the vaccines and then you'd start the medicine and then, things would be fine after a few weeks when the vaccines kick in. There have been some more recent studies that may suggest, vaccination by itself may not be enough and that there was still a little bit more breakthrough meningitis than they would expect in that overall population of patients getting that medicine. I think our experience may be, we actually, knock on wood, have not actually had any, patients with a breakthrough infection, even if they weren't already on penicillin. So newer starts, I'm tending to keep them on the antibiotics. That's the current guidelines. Folks that have been on it for years that never were on antibiotics, I'm not introducing it necessarily. But that's why there was just more recent studies that came out kind of showing that infection risk was possibly higher than we thought.
But we've always had to use vaccines and antibiotics from the start of using complement inhibitor therapy, but you can stop them. That's your question. So if you're taking Solaris, you can stop antibiotics about 4 weeks after you finish it, if you finish it. With ravulizumab, it's 8 weeks later because of how long it lasts. But we have everyone on prophylaxis, antibiotic-wise.
It just depends where you are. In Europe, especially pediatrics, they're all on lifetime prophylaxis. In the adults, especially outside in the US and Canada, it's not so common. And I thought a couple of years ago there was going to be a movement to change when there was some CDC guidelines that changed, but it just never seemed to occur. And I think meningitis is still a rare to be exposed by it. We don't routinely do it at Ohio State, but a good example of a young female on complement blockade therapy moving into a dorm or college dorm, she got prophylaxis while she was living in the dorm. So I don't think there's an absolute right answer. I think there's more of a lean toward antibiotics. The concern is always, are you going to get resistance? So when you need them, they're not going to work. So it's not without a price, even if it's well tolerated. So it's a good question.
my question was kind of piggybacking on a question 2 questions ago, so I may be going back a little bit. But regarding the playlists, and not getting them during line placements, all my daughters have them during line placements. So my second question is trying to have it also, she gets that usually like when she gets the line placed during the act.
I mean, it won't do anything good or bad, tranny acid. It's just unnecessary.
I'll repeat the question so Claire doesn't have to
Sorry,
scold you
sorry.
in public again. Tranexamic acid or platelets with a line placement. I agree. The main thing it does, it makes a person placing the line feel better. That's what it does. And when we have people insisting on it, we kind of say, go ahead, do it. But is it making people feel better? And if they're relaxed putting the line in, then maybe it did its job. But is it really necessary? No. And what institutions, after a while, like our institution doesn't even come up anymore. But if it's a new idea, they're just going to see 7,000 platelets and putting this line in, and the answer is going to be, oh no, not until.
And I had brought up that question because I've received having a GIP during receiving apheresis, and as part of apheresis also receiving steroids. So was there a question of the steroids and
I think that's sort of a question bleeding during plasmics, during treatment for TTP and platelets. I think that falls on that's judgment. If someone was worried about the contribution of that low platelet count to bleeding, but you have to keep in mind, just like ITP, you're still making those platelets. So that number function may be better than the number, but I understand why they gave them to you at that time. Yeah. But like Marie said, when you're giving plates with ongoing treatment, that tells you that's when they're not the issue.
But we mustn't forget a lot of high dose steroid for some patients really can cause a number of significant side effects, and widespread GI bleeding most definitely can occur and can just aggravate the whole, acute therapy because you're then limited in what you can do and what you need to do. That definitely occurs every now and again. Although in fairness, we don't use such high doses these days.
We even had a little lunchtime conversation about, do you even need steroids at all? Which is, I think, a very good question. In someone getting rituximab very early. If you look at Marie's data and some of ours and the curves of when people recover, it doesn't seem like the steroids makes it happen quicker once you're on rituximab. So I think it's an old habit that's never going to die very easily, but it's something that you do that people think is important. And it may help, it may hurt. And I think there's still, as we've said, as we get into an era in the future where I think plasma exchange is less important and there's more targeted therapies, whether it's caplacizumab or recombinant and TS13, I think you're going to see a reassessment of what we're doing and how effective it is and kind of redoing the immune suppression, or at least understanding what we're doing. Did I speak out of line?
No.
You did good. A question from the audience at home. I'm going to generalize it was specific to infection, but in general, if a patient presents initially with TTP with some sort of trigger infection, pregnancy, illness, something like that, would you expect them only to relapse presenting with that trigger? So like they don't have an infection or they aren't pregnant, are they free from the risk of relapse? And we repeat that into my.
So the question is infection, cancer, anything that triggered your first TTP episode, would that automatically trigger your next episode? What do you guys think?
Would you be able to have an episode even with that initial trigger?
So the answer is yes, you would be able to. So if an infection triggered your initial episode and then you subsequently become pregnant, that can and does potentially trigger a relapse. And so there are occasions where you may only have one certain type of trigger, but that's on a case by case kind of basis, and only time would really tell you. You're theoretically at risk though, regardless of what the trigger is.
There was another question about visual disruptions in TTP as well. There's multiple patients who have reported visual disturbances in the days leading up to their first or later TTP episodes. Is the underlying cause known? Is there a reason you guys would think that there was visual changes for these patients? Or is there any research being done in this area?
So for immune TTP, I'm sorry. I thought because Claire said it, I was okay. I was off the hook.
Tricked you. Phil.
She did.
Watch
So the question is visual symptoms in the lead up to an acute TTP episode, or as almost a precipitant's wrong word, the presence pre a relapse. What was the next bit, Claire?
Is there
Yeah.
being done and
Okay. Is there a reason, and is there research being done? So the lead up to an acute TTP episode for someone who's never had it before can have all kinds of strange symptoms. And the particular worry in younger patients is that they come and go. So you think, oh, you know, I can't see well out of my right eye, and 20 minutes later it's fine. And then 2 days later it may occur for 40 minutes and then resolves. And then your speech is funny, and then it gets better after a couple of minutes, or you feel flu-like. It's that build-up over a number of days until it gets to a critical point that means that you need to go and get to be seen, usually in the emergency department. But do we see these symptoms pre-acute TTP episodes? Yes. Can they happen in patients who've had TTP with a normal ADAMTS13 where it starts to decrease? Yes, it can. It's not common, but there are about, I'd say, 40% or so patients, in my experience, who, when the ADAMTS13 is dropping, they can get some symptoms or they can become very symptomatic. The lion's share are absolutely fine. And visual disturbances, if they've had visual disturbances for the first episode, or headaches, or more extreme lethargy, or personality disorder, you know, they feel more anxious or depressed, is definitely a feature. But it is patient specific. So why does it occur? We've already discussed about microvascular thrombi affecting any and all of the organs. That's what's happening, but it's not a permanent thing. So the ADAMTS13 has dropped. You can get these symptoms coming and going, and it's only when the platelets drop that it becomes really very obvious. What we've learned over the last few years is from congenital TTP. So congenital patients can have a normal platelet count, they have a very low ADAMTS13, and they invariably have these recurrent remitting symptoms, including visual disturbances. So we've been able to track what happens with congenital patients and think about it in the immune patients and vice versa. So it makes perfect sense to have symptoms if you've had a mutant TTP when the ADAMTS13 is dropping, but it isn't in every patient. That's very long-winded, but does it kind of explain a bit about why you might have symptoms? And the worst case that we have, this is so extreme, it's N=1, and the patient knows that I always tell this story. It was very early on in my career when I was young and fresh in TTP. And this patient had a normal ADAMTS13. And then she came into clinic on a Friday with her dad. And they were absolutely bereft, the pair of them. And she was about to commit suicide. Completely out of character. A wonderful girl. The only thing we found that her ADAMTS13 had dropped to less than 5%. So we, as usual, then even gave her elective rituximab. Just before the 3rd week, when she came back for her elective treatment and there was an increment in her ADAMTS13, she was completely fine, absolutely nothing, completely back to her normal self. Now that is extremist, and it's N=1 patient, but her behavior has been similar in a subsequent episode a number of years later, where at a neurological level, it's almost what we call like an encephalopathy. It's like, almost like the outside of the brain, not a stroke inside of the brain. But the microthrombi can cause any level of symptoms. And we can, in rare cases, see that completely resolved by normalization of the ADAMTS13. It is extreme. I don't think you believe me, do you? It was one of the most frightening experiences.
I think
I've
you have
ever
to always
been.
think about their symptoms from an acute episode. And those, you can't separate visual from motor, from confusion. I had a woman, young college student, who came back to the ED because she was with a tutor for college math, and she was having trouble with simple aspects of like the addition part. And the guy said to her, "What is the matter with you?" And she said, "You're right. What is the matter?" And she was caught early in this stage of a relapse. There's also symptoms that we've now understand that happen in recovery when your ADAMTS activity is likely normal. These long-term, they're neurocognitive defects, they're headaches, some mood issues. Those are a little bit different, but they do get a little gray. You have to remember, we're still learning how common those are. We're still learning why they happen. And I'm sure the ADAMTS13 is involved in it. I don't think it's the only thing that's involved. We're still learning that. So I think that the idea for even us who see a lot of TTPs, you've got to keep your eyes open and always question what you're seeing, because it doesn't always, we know what the norm is, what the textbooks say, what we tell people at lectures, but individual people can do individual things and you have to be really careful.
Our daughter has congenital TTP, and she eventually wants to have children of her own if she can. Have you guys seen patients that have had planned, successful, proactive pregnancies with TTP? And if so, what are the proactive measures that were being taken?
I'll repeat the question before my panel gets in trouble.
Oh, yeah.
The question is congenital TTP, immune-mediated TTP pregnancy. Can you do it? Is it safe? How do you do it?
Yeah, I mean, I would say absolutely. We can and do have patients with both congenital and immune TTP go on to have, successful pregnancies. I think it requires additional monitoring of the ADAMTS13 activity in the immune-mediated case for sure. And then in terms of congenital patients, some people are already on prophylaxis with plasma or Adzynma or other things. But in the case they aren't, it's something that we would most likely institute, at the time of pregnancy. And the frequency of that treatment may even increase as the pregnancy, progresses. That's a bit not super set in stone and a bit case by case. You have to see how things go. But with proactive monitoring and treatment, we can and do have patients successful.
Do you have anything to say?
Who, me?
Yeah.
Oh, I've only ever said no to one patient about getting pregnant. Otherwise, literally, they don't stop. It is the year of the baby, 2024. I'm not joking you. Everyone is pregnant at the moment. So absolutely. I'm not going to be complacent about it, though. We do need to monitor ladies, and particularly in congenital TTP. We do like to have delivery by about 37 weeks. For some reason, at that end, where the von Willebrand level gets higher, it does seem to start irritating the disease. But we are in a new era, and that era is recombinant ADAMTS13. And I think, that's going to give the best optimal care, but we still need to watch them closely, but absolutely support it.
I think the old answer used to be doctors would say you can't get pregnant because they didn't know what to do. I think we understand what to do. And I tell patients, you can absolutely get pregnant, but it takes a little bit of a commitment on your part for the monitoring. I think what brings the congenital and immune together is the ADAMTS13 activity. If it goes low, at least 10%, if it goes lower than 20, if it goes low, there's going to be a problem. So whether it's congenital or immune. So for congenital, it's increasing the infusions of the recombinant. If it's immune mediated, it's talking about treatment to improve the ADAMTS13 activity. You can't watch them and say, this one might be okay. It won't be okay. So whether it's cyclosporin or rituximab in the immune mediated, there's ways you can do it. Again, it takes some effort and monitoring, but it can be done safely, I think.
In relation to the pregnancy and stuff like that, I know mom and baby are most likely going to be fine until the pregnancy happens and then afterward. But I know that if mom has to get rituximab, it's going to kill all the B cells for mom and baby, I think. So
You can.
is there anything you have to do with the baby after all of its B cells are gone? Like no family or friends visiting or anything like that, or like any precautions?
That's a really good question. So I'll read it out because I've remembered. If you need to have rituximab during pregnancy because the ADAMS is reduced or you're having a relapse, the impact on baby. Who wants to answer that? Thank you.
Oh, me, good.
No, you're both looking at me going, right, you get on with it. You think you know your stuff. So, of course, you know, we do worry about therapies that haven't been given frequently. And who was it you that you presented some, was it you? Yeah, that presented some data this morning. And there is limited data of rituximab in immune TTP, but not in autoimmune disease. If you think about it, rituximab is probably better than having things like high dose steroids throughout all of pregnancy or cyclosporin. Who likes cyclosporin? I think it's fine. And I think it's fine because if you need to give it to a lady, it's because it could lead to a precarious position with both her and the baby. What happens to baby? Well, we do check the blood counts and they've been normal. I've checked CD19, which is kind of like this side measure, and they're low in baby. Do we keep baby from visiting friends, family, and everyone? No. So don't forget, they are getting mum's antibodies. So the only caveat with Ritux has got something to do with TB. If you've got a high prevalence region, so some areas of London, for example, not all of London, have high TB risk, and you can't give them the BCG vaccine. That's the only adverse event that I know about. We haven't used lots of Ritux in pregnancy, in all fairness, but we have used it, and we do monitor mum and baby and have not seen harm.
I think Marie and I just went through a process with a couple colleagues writing a paper reviewing 100 years of research in TTP and the progress. And we went back and looked at all the things that people worried about over the years. And one of the things people worried about was the patient getting rituximab, that, yeah, it seems to be fine, it's safe now, but we'll just wait until. And there really has not been significant infectious complications in patients getting rituximab. And I think we use that to give us, and it's been used for what now, 10, 14
20 years.
Yeah.
You were slow to start using it
Well,
in
we
the
had our
States.
own little action going here in the States. But I think
Very slow.
it is safe. We think it's safe for baby. B cells do drop
Yeah.
in baby, but you have to consider both sides of it. And an undetectable ADAM-TS13 activity in pregnancy is going to end very badly. So in that context, I'm very comfortable using. We use cyclosporin because it's studied in transplants for many years, and then rituximab soon after doesn't work. So again, more effort required. Do I think it's safe? Yes. I sleep much better at night when my patient gets rituximab when they don't with undetectable activity. Yes. Go ahead.
Rituximab use that obviously depletes your immune system. How common is it for patients to receive IgG to boost their immune system after their immune system's been wiped out from rituximab? And is there any correlation with relapse or lack of relapse because of the IgG, or is it just not correlated?
The question is, post-rituximab with depletion of B cells that make antibodies, does anybody routinely give immunoglobulin, and is there a danger with it? Yeah.
Ritux doesn't wipe out your immune system. I think that's the first important thing. I think there's been a lot of Chinese whispers about Ritux. So it does reduce the B lymphocytes. All the antibodies that you formed all your life will still be there. There is a period of about 9 months where you can't effectively mount an antibody response. There's no real point having a vaccine. And if there's a bug that you've never been exposed to, you theoretically will not be able to mount an antibody response. it does not appear to cause worsening viral infections. Anecdotally, the patients who have had Ritux around the winter period almost seem to have less viral infections than more. And that makes sense because it's a B lymphocyte, although you have to form antibodies to it. The vaccine side of things is quite interesting. So obviously during the whole COVID situation, if we can remember back that far, sometimes patients got vaccinated because they were just called in and they'd recently had rituximab, so their B cell numbers were very low. So they didn't mount a response, but as the B cell numbers started to go up, the antibody levels to the COVID vaccine all started going up as well. So in fact, they were obviously doing something. Do you relapse once your CD19 level returns to normal? No, not necessarily. I mean, you won't relapse if it's low, but it doesn't mean the minute it goes to normal, everybody relapses. Don't forget, we've got this biomarker. We've got ADAMT13, which is a far better predictor of relapse than CD19. I've got one patient on two patients on regular immunoglobulin out of 450. Neither of their need as a kind of CVID, that's chronic variable immunodeficiency, diagnosis was related to the use of rituximab. They probably had it already. And they, in fact, one of them definitely had low immunoglobulins even before he treated her with Ritux for acute TTP. So no, we don't. Have you got any patients on immunoglobulins?
No. It
Have you?
really has not been such a profound immune suppressant as people were worried about. There was a lot of concern that just wait, look out. It really hasn't materialized, thankfully.
Yeah, my daughter's immunoglobulin was like really down low after, I don't know if it's coincidence or what, but they had her on IgG.
They went low after the rituximab.
After the
Yeah,
they
it's
tested before, and then they tested after. And then they got to a low point, like they were tolerating relatively low levels for quite a while, and then they're like, this is too low, we need to treat.
But was she having infections? Okay. Sometimes doctors can oversteer things and overthink things a bit. That's certainly you would expect antibody levels to drop, but do you routinely measure them, Marie?
Yeah.
You do really?
What, immunoglobulins?
Yeah.
Yeah. We do it every clinic visit.
9 months roughly to recover your B cells. We don't routinely do it unless there's problems with infection. And that's when you would treat somebody. Yes.
My daughter is on a new treatment. She has congenital TTP. We've always been told that she can't have Advil or ibuprofen. Now, with this new treatment, her platelets are very stable. Is she allowed to have that? Tylenol just doesn't help. Why?
So the question is, antiplatelet drugs, ibuprofen, aspirin, and some with congenital TTP on treatment. Senthil, what do you think?
Yeah, I think it'd be totally fine. There's really no issue, especially if her platelet count is normal. She's doing well. Otherwise, I wouldn't worry about it.
One more question. Regarding birth control, what do you do with girls with congenital TTP women?
It's really important, and it's something that can be forgotten.
Birth control and congenital TTP is the question. I'm enjoying this very much today.
Keep laughing, boy. Keep laughing. So, estrogen-based therapy. So a number of the congenital ladies before they're diagnosed will have gone on the pill, and they'll start having TIA type symptoms and terrible headaches. And then they stop it, even before they know they have congenital TTP. Estrogen-based pills will probably exacerbate their symptoms. You never say never because we are in a new era, but I would start off either with progesterone only, see how they get on with that. If they're all right with that, then they can think about having the implant. More and more these days, coils are used even for girls or women that haven't had children. In the old days, like 5 years ago, it was only if you'd had previous children. But now I think they're a bit more receptive to using coils, and they can use with the Mirena coil, which has got progesterone. So there's loads of options. I would avoid the combined pill with estrogen in the first instance. And then at the other end of life, HRT. So I'm not going to say don't try it, but I think if you do try it and you've got congenital TTP and you get more symptoms, you need to stop it or think of an alternative. And there's loads of alternatives these days. So plausible, but we just need to adapt things a little bit.
I think it's sort of a risk benefit thing. So I agree with you. If it's only for birth control, there are probably better ways for a congenital TTP patient. But I have a congenital TTP patient who needed low dose estrogen for a gynecologic endocrine reason, not for birth control. And she was aiming her physician for physiologic doses. And we said, I think it's reasonable to do it. We'll watch your blood work carefully in the first couple of weeks because she wasn't on prophylaxis. She's had a very unique sort of presentation where only every couple of years, and she's elected not to. So in that situation, I think being careful and mindful of why you're doing it and watching them carefully, it can be done safely. But if it's just for birth control, you have to be careful, I think.
Does the same thing apply to ITTP?
Does the same thing apply to ITTP patients? I'm taking the mickey out of him, not your question. That is a very important point, actually, because back in the day, we used to say not to use combined oral contraceptive pill or HRT. And we did have some ladies where it was precipitated by pregnancy or indeed HRT. I think we're in a different era. Now that we're monitoring so closely the ADAMTS13, if the ADAMTS13 is in the normal range, normal's normal. So you use what you need to use. And if you're not having symptoms, yeah, I think it's absolutely fine. It wasn't the original advice, but we only knew what we knew at that time. And we didn't have the longevity of monitoring ladies. Do you do the same? Are you cooler with immune?
I still tend to maybe like to avoid estrogen. I mean, I do have that predilection, but if you know, like Spira was saying, if it's not just for birth control purposes, but we're trying to control, you know, abnormal bleeding or other problems that, you know, can typically happen, then like Marie said, we'll just monitor more frequently, right? It's just like any other estrogen exposure, like during pregnancy or something like that. It's basically more frequent monitoring at that point. So it's not an absolute.
I mean, 10 plus years ago, these questions were asked and you would get 5 different answers. And the honest answer is we don't know. I think we know a lot more now. So when I'm asked whether it's the vaccine, can I get pregnant? Can I have surgery? Should I go on a cruise? Is it safe? I ask back to them, when's the last time you had your ADAMTS routine checked? And that gives you some comfort. It's not perfect. So it's not necessarily any particular triggering event. It's the event, whether it's a vaccine or COVID or infection or pregnancy, it's the event that happens. What was your risk for TTP? If your ADAMTS was less than 20%, that is probably a problem or could be a problem. If it's not, it's probably not going to be a problem. That's a good general rule. Yes.
Well, we're on the subject of like medications and things to avoid. What are your opinions on things that contain quinine, like malaria-like medication or tonic water?
So the question is quinine and tonic water and the reports of thrombocytopenia associated with quinine just by itself, a low platelet count, but also there's reports from Dr. Georgia of an HUS type picture.
So Fever Tree is a type of tonic water that doesn't have quinine in it. So you don't need to use Schweppes. Is that all right?
Now I must
So
say,
that answered. You didn't know that. You didn't know that, did you? Did I tell you?
tonic
I
water.
thought Fever Tree had quinine. Yeah, no.
No, Fever Tree doesn't
I
have
used
quinine.
to think tonic water with gin was an old thing, but I saw a lot of gin and tonics last night. And there's somebody,
Not from
there's
me.
somebody here. who-
Not from me.
The solution might be, we heard a report that somebody put gin in a beer last night, which would take care of the quinine issue completely. You get your gin and beer, you're good. So we're doing research as we are here.
No, jokes aside. So actually, Fever Tree doesn't have quinine. So that's one less thing. And there was this myth that you couldn't have gin and tonics. I mean, there wouldn't be enough quinine in it anyway. So feel free. Quinine has been associated possibly in the past with antibody-mediated TTP. There are other options for malaria prophylaxis these days, so it can be avoided. If your back's against the wall, you just take the quinine. You know, if you've got acute malaria in the middle of a country, you just have the quinine. Because invariably your ADAMTS13 will have been checked and it's normal before you went anyway. So not really. There's very, very few drugs that cause TTP.
It's more likely to drop your platelet count unrelated to anything we talked about.
Yeah, quite. I forgot about that. Yeah, quinine, malaria makes you quite sick, doesn't it, sometimes?
I have a question. Have there been any studies like using CRISPR in TTP? And do you guys have any thoughts about how?
So the question is regarding CRISPR and we'll say gene editing, gene therapy in congenital TTP. Senthil's our resident congenital expert now.
I was gonna say, I don't know if I know the latest stuff about CRISPR and like what they're looking at. I think it's a fantastic idea though.
They've just published in hemoglobinopathies
Yeah.
in New England. So it does sound really sexy, gene editing. But would you want to have that level of conditioning before you got the genetic back to you? That's what we need to look at. So it's not just that they give you this new genetic material to overrun what's already there. You've got to have essentially a bone marrow transplant type conditioning regime before, and all of the risks attached to it thereafter. So it's not just a new sexy technique, or you take recombinant ADAMTS13 weekly.
So yeah, and what Marie is alluding to there is in the sickle cell disease space and hemoglobinopathy space, essentially they're having this discussion right now because when she says conditioning, what she's talking about is the conditioning chemotherapy regimen, which is really high intensity chemotherapy that wipes out your existing bone marrow completely. And then you're essentially given like a bone marrow transplant, like a replacement set of cells that have that new gene edit in them. But the root of that question is and there's a host of long-term complications and other issues that can happen just from receiving that level of chemotherapy, even if it's for a short period of time, that have long-lasting consequences. And so the root of the question is the disease that I have and its current management, is it severe enough that it would warrant going through this process? And even the conditioning regimen itself, it's a small mortality risk, but it's still a mortality risk. So some people can just die from receiving this chemotherapy itself while in the hospital, those first 100 days with infections and other things. So that's the question that we kind of have to ask ourselves. So for some patients, it may be the right, if that, science gets that far, it may be the right thing to do. But the question is with recombinant now and things like that, is the disease going to be so bad to warrant it? That's the open question.
It's a very good question, but talking to my colleagues in the sickle cell world, so with those technologies, you increase the fetal hemoglobin, is one approach. So you decrease some of their complications, but they still have many complications of their sickle cell disease. So when you do this gene editing, you're not guaranteed to have normal levels. You might have levels that are 20%, 30%, that might prevent relapse, but they may not prevent long-term complications that we're still trying to learn about. So it may not be a perfect solution. I think we need to really think through all aspects of this. It doesn't mean you're going to have normal levels. And I think analogous to this is the approach that you've probably all heard about, this CAR T cell therapy, so modified immune cells to attack cancers. The approach is now being thought about and discussed with immune-mediated TTP. So can you create a modified T cell that's going to be modified, injected into you to kill those B cells? And that'd be great, that's causing the disease. But you might cause other autoimmune problems. So you've got to think about the upfront and the back end risks and what are you getting from it. I'm not telling you it's a bad idea, but I'm saying you need to be careful before anybody in the room signs up.
Have we put you off? No, from gene editing. Yeah, I mean, there's so many changes happening and new therapies coming through. And yes, they could be applicable to TTP, the immunocongenital. But, as we've described, there is a bigger picture. It's not just CRISPR. There is a whole barrage of things. And then you need to bring back to what the current therapeutic landscape is. And is that safer and easier? I think that's all we're saying.
I mean, compared to hemophilia in kids who there was a big push, there still is for gene therapy to improve their own production of factor VIII. But now there are agents that you could, and for a young kid who has to inject themselves intravenously with clotting factor 3 times a week, it's a big issue. But there are now products where kids get injected just under the skin. I shouldn't say just, it's a kid getting stuck by a needle. But a sub-Q injection once a week or every 2 weeks makes you rethink, is gene therapy and its risks really worth it? And I think, as great as that sounds, give science a couple more years and there may be better options. So I say kick the can down the road a few more years and see what better options that we have.
And the reason we say that too is because so far, with like hemophilia being that prototypical genetic disease where there's a factor that we can measure the percentage of, and then after gene therapy, they can measure that percentage, they're still only achieving like 10-ish% factor VIII expression. So even after the gene therapy, they're making more factor VIII, which they never did before, but it's not like it's normalized, you know? And so seeing those other disease states and how their gene therapy journeys have gone, I think that's basically what we're getting to is, yeah, the technology maybe needs to get a little bit more sophisticated before, for the average patient, it makes sense in our situation.
We went from CoA, from fresh frozen plasma several years to CoA to now the new drug for our daughter. And we've always done proactive 2-week treatments, but she has been complaining of occasional dizzy spells, stomach aches, and now we're starting to question, is 2 weeks enough? Should we be looking at weekly? Can you guys comment on, are most your patients weekly or bi-weekly? I know it differs.
Yeah, I'll let Marie's got a big cohort that she follows, but I'll repeat the question first. So congenital TTP, plasma, CoA, recombinant, especially recombinant, now that we can give better and reliable doses, how often may it need to be given? Is that?
Yes.
All right, I did my part. Your turn.
Okay, so I heard earlier from Marshall, who I think he was here, about the issues that you face, which are politically with your healthcare compared to our issues. So we all have issues. Appreciating that we move all the politics out of the way, what would be the best care? You describe a journey where you've changed therapies, and indeed that's what congenital TTP has been in the last few years. It has been a journey to try and optimize care. And it's been changing and swapping between plasma and factor VIII concentrates and trying to determine the best dose and the best frequency. In the old days, it used to be every 3 weeks to just give a bit of something and that should be fine. And you have described beautifully where your daughter, it has been okay every 2 weeks and now is having symptoms which would be in keeping with what we call non-overt symptoms in congenital TTP, and they are well now recognised. The best way to approach that is bringing back some of the politics, is to give it every 10 days, see if you can improve the symptoms, and if not, then give it every week. The lion's share of our patients are on weekly treatment, having gone through all of this over a number of years, seeing how they are increasing the dose, increasing the frequency, so that we can sort the symptoms out the best that we can get them. With plasma, we see usually day 8, day 10, or indeed even with recombinant, that the symptoms start to come back. And that's when we move them to weekly therapy. So we don't necessarily always go straight in. My opinion for the future is that we're going to even have to consider more frequent treatment than weekly in some patients, particularly those who have had disease presentations much earlier on. So we see a good increase in the ADAMT13, but it does drop. And when you recheck it a week later, particularly for the youngsters who presented earlier in life, their levels are back down to very low. Whereas those who present later in life, who have needed a big trigger, they have much higher levels that week. At the end of the week, you know, they're running sometimes 15, 20%, whereas the youngsters are back down to less than 5. That means we're not giving them adequate therapy. So for your daughter, if you can, I would suggest moving to weekly if she's getting those symptoms. I am not her hematologist, so don't shoot me down. and I can't comment on them. But I think in the future, we need to understand more about what we're trying to achieve. And I think that we all need to. So medically, we need to understand what is the optimal ADAMTS13 and the optimal dosing regime for all patients. So it might be that they get like 20 units per kilo twice a week rather than 40 units per kilo. I don't know, we need to look at things like that. But if she's getting those symptoms, she needs, do you know these, are they under you?
No.
Oh, do you know these people? Huh? Who?
Marshall.
Oh, Marshall. Oh, that's fine. That's fine. Yeah, is it Marshall? Yeah, yeah, Marshall.
I think what you're going to get is routinely insurance will push back.
Yeah.
What they do, the FDA, I think the labeling is your interval before is what your interval is on Mercom, because that's how the study was done. And most people were on every 2 weeks plasma because it was just, people were, for obvious reasons, resisting plasma every week. It's too much, the time, the reactions, the effectiveness. So they're going with that. We're going to eventually get more data to show relapses. I think most people will accept 10% is just fine for relapse. That's not really the goal. The goal is preventing these long-term complications. And once we get more data that shows higher levels are more important, I think they'll reliably provide it more when they're kind of forced to, I guess, for lack of a better term. But I think also more frequent dosing is what's going to happen. But where I think you're going to see the future of alternative forms, meaning subcutaneous dosing where you can do it at home by yourself. And it's also cheaper for insurance companies. They aren't paying a hospital to do it. They're just paying for your drug, and just like an insulin shot. I think that may be in the near future, knowing what levels to achieve. And with giving a dose that we know compared to plasma, we'll kind of know how to achieve. Like we know the typical dose of 40 units per kilogram is about 5 days that you're above 10%. And that's probably not good enough, but it's the best. It's better than we had before, and we're working toward that. So what level do we need to prevent those complications in both ITP and congenital TT? We're going to start in congenital. I think studies have to sort of show that then we can aim for that level.
So we're 14 days now. You recommend pushing insurance to try to get to 10?
Yeah.
If that doesn't work, then go to
Well,
3.
I think practically what might be easier for you, this depends on so many factors locally, right? Your insurance and other issues. But I have successfully gotten a patient approved from 14 to 7. I think they'll understand that a little bit easier. It probably makes more medical sense to do what Marie said, to go to 14 to 10 to 7. But that many changes, they're just going to be like, what's going on here?
Yeah, yeah.
And so I think practically speaking, just going from twice every 2 weeks to weekly is likely the best bet in terms of actually getting approved and going through. And, N of 1, but I've successfully had a patient get approved for that.
Did you have your patients document that they were getting symptoms to push them to a more frequent?
Which is really just going to have to be in the medical records. So we're going to create some work for Marshall here. Marshall just has to document what's going on. And trust me, when Marshall asks them for it, they're like your mom. The first answer is no matter what the question is. And they're going to say no. And it's going to be a peer-to-peer with Marshall and them to tell them exactly why. So it's not going to be, they don't want to globally approve it for all their patients, but they're going to make individual exceptions. And I think they will once Marshall explains to them what's going on. Most of the time, the peer-to-peer, as painful as they are, they're usually physicians who still are physicians and still understand and will usually listen to good reason, if you got a good reason for it.
Thank you, guys.
Yeah, a couple of questions that we get to. There's one about avoid the use of steroids for treatment in patients who have or who want to avoid.
So the steroids, the role of treatment, and do you absolutely need them in ITTV treatment?
Yeah, so, I mean, I think the standard of care currently is to use steroids for the upfront treatment of a relapse or a new episode. I can tell you that Spear and I have published case reports of patients in whom we've treated without needing to use steroids, and we just use rituximab and other things alone for certain less severe cases. But that would be very much a case by case basis situation, and how severe things look and things like that. It's certainly not standard, and you'd have to, have that discussion with your physician and know that you're going out a bit, on a limb there. But depending on the side effects and things like that, it's possible, but it's not likely that it would be pursued as like an initial option.
So well-intended physicians always kind of lose track of the steroids, and before you know it, somebody's on steroids for 2 months and 3 months, and there's always a fear of tapering too quickly. I think our experience is typically they get on it initially, but once we get the rituximab going, we'll try to get them off it within 14 days, if not 10 days, because I think the real benefit is the rituximab, and the long-term benefit, not the steroids so much. They do more harm than good, I think.
They do.
overall.
So the reason I'm sitting here smiling is for years I have asked clinicians when I do talks, how many of you would take high dose steroids? And nobody puts their hands up. And then how many of you have been on steroids? And there's often a few hands up. They're horrible. Have you been on steroids?
A short bit of time, yeah.
Did you?
I threw my back out, so I begged my
That's
colleagues. to
different.
prevent
That's
it.
just, that doesn't count. That's homeopathic doses in comparison. I think it was probably a Smartie and they fooled you.
Oh, good. I asked for
They know
oxycodone.
what
They
you're
gave me
like,
prednisone,
yeah. So, you know, it's all about being measured. Having high dose steroids at acute presentation, when you've got multiple organ involvement, particularly heart and brain, as far as I'm concerned, is a must. But do you need someone to be on high dose treatment a week later? Absolutely not. We've got a new pathway and protocol, which means the counts improve quicker. So we've got safety. And then it doesn't matter really how long it takes for the ADAMTS13 to normalize, as long as you haven't caused hypertension and diabetes and all those issues that are going to put you at risk in the future. The AVM thing is very, very interesting. The rheumatologists who use a lot of steroids, our institution, they have an AVM, which is avascular necrosis, which means you need a hip replacement, essentially. It's horrible. They have a rate of AVN of between 15 and 20%. That's very high. And it's because people start steroids because they're good, and then they can't finish them. So I think one of the things that we need to do at an international level is to make people stop them and not go on infinitum. And I'm sure there's many of you here who've been, if you're the old guard who've had TTP in the past, you've had a lot of, yeah.
But when you ask those physicians, do you stop it within a month? They say yes. But in real practice, they don't. They worry. Well, they say they do, but they don't. It's just they worry about stopping it.
Such a long time, isn't it?
Well, it's too long. I agree.
So regarding the steroids, written down some of the guidelines for that, because unfortunately it's always
Yeah, no, so the guidelines, not really with regards to when to stop.
The British guidelines talk about the high dose of starting.
High dose to start, depending on the degree of severity, but I rarely use a gram unless it's really severe. But ITP is now, because I do the same, you know, have you taken steroids, you know, to the clinicians. They now have limited it to 3 weeks, which is really a massive change. And I think a lot of other immune doctors have tried to follow suit with that. So in ITP, some patients were on them for years, months and months and years. So I think the important thing is that people are more cognizant of the medium and longer term effects of steroids, more than they were, let's say, 10 years ago, where they just were started and never stopped. A gram stat daily.
Like a Solumetrol.
Methylpred, yeah, it's massive dose, yeah.
I mean, all the debates we have about steroids, high dose, regular dose,
Yeah.
rituximab, a lot of these things miss the point of you can get directly to the source of the problem with caplacizumab, which will block the formation of microthrombi. So there's a lot of effort around a lot of things, and that really gets
Except
right to the
in
point.
Canada.
Hit the Canadians
You
hard
can't
there.
get it, can
Yeah, I
you?
was just gonna say Canada, they didn't.
No, a gram of methylpred's been standard for many, many years. And if you've got someone that comes in a coma or, you know, has got multi-organ involvement, that would be standard. It works quick. So acutely, as 1 off or 2 days, is different from patients still being on high dose 60 milligrams a day or 40 milligrams a day 6 weeks later. And the risk and side effects from big pulses are much less than high dose over a longer period.
So those steroids take 2 to 3 weeks at least to start to improve the ADAM-TS13 activity. Marie's talking about the acute inflammatory, which makes perfect sense. Steroids do work in terms of recovering the ADAM-TS13 activity. If you stay on 60 milligrams a day, your ADAM-TS is probably going to be very good, but your bones are going to crumble, you're going to gain weight, you're going to have risk for diabetes, you're going to be hypertensive. So you've got to balance it. In the past, our old teachers, there weren't many other options, or it was throwing chemotherapy drugs at people semi-blindly. So we've got better options today. So they're really not as necessary. In the past, they were more necessary. We shouldn't see AVN in the future in our patients.
In rheumatology patients. I've got one patient that developed AVN, actually.
But I think it's certainly less than 20%.
Oh, way less. Way. I mean, that's.
And I think the rheumatologists tend to use even lower doses. We're talking 15, 10, and it's still there. So yeah, I'm very worried. I think overall, this sounds funny. I think overall we do more harm than good with steroids. When you look at the whole big picture,
longer term,
from beginning to end, I think you have to be really careful. Yes.
In terms of medication use in basically before you start one that's developed sensitivities over a long period of time, steroids are using that as well, correct? And have we moved away from that to Benadryl and PPIs, or is it still like between all those three?
So the question about pre-medication before plasma reactions, so proton pump inhibitors, histamine blockers like Benadryl and steroids. I think that's short-term steroids with a clear use to block the reaction. That certainly makes some sense. I think where we believe the problem is the long-term, where they're kind
and the much lower doses, pre-meds.
And I think, I mean, this may be a bit beyond the scope of that question necessarily, but I think these days we also have potentially in patients who have a lot of reactions or adverse issues with plasma products. Now that we have caplacizumab, they're again case by case basis, but that's a patient who I would consider treating with caplacizumab along with our standard immunosuppression without using plasma exchange at all, maybe just with closer monitoring while they're in the hospital. But those are actually the kind of prototypical situations where I would consider that approach. And I think most of us would consider that.
For prior to planned surgery, can you speak a little bit to why rheumatologists would want to test protein and creatinine ratio?
The questions are lab tests you might get prior to a planned surgery, and the urine protein creatinine ratio, I think, is probably what they're referring to. That's a marker of chronic kidney injury. So we've now started in our cohort of patients checking urines regularly, looking for that, and working with some nephrologists at our institution, as well as the gang from Germany, Linus Volker and Paul Brinkhardt. We've started doing that, not for acute, but for chronic reasons, trying to better understand, is there a chronic kidney injury? I think a lot of us think it could be, and we're watching for that. In terms of prior to surgery, we'll routinely check the ADAM-TS13 activity prior to an elective procedure. If someone needs an emergency surgery, we're not getting an ADAM-TS13 activity and getting it back the next day, obviously. But I think that's part of, like pregnancy, it's mitigating the risk. So if the activity is normal, there's no guarantees, but I feel much better about that surgery happening. Rather, if it's an elective surgery and you've got a 10% ADAM-TS13 activity, I think we talk about rituximab to improve the activity prior to that elective surgery.
Do you have time for a couple more questions?
I want to ask about, so I understand in the UK, I don't know if you call it a TTP center, whatever it is, but also include there to you to be able to treat maybe anxiety, depression, things like that. And I never hear that talked about. Like how does that work in that center?
So it's asking about in the UK what we do to try and support anxiety and depression and other let's call it psychologically based aspects of the disease that previously have not been very well touched upon. So yes, in England, not the UK. And I have to keep reminding myself, although we do work very closely with our partners, we have 9 treating centres in England, and all of them have, all those 9 centres are the centres that treat TTP. There is no other centres that treat TTP. And within that centre, they have the remit, a number of remits. So they have the medical team, they will have the clinical nurse specialists, and we all have a clinical psychologist. In years gone by, we have concentrated on just trying to get patients through the acute TTP episode, and for some time patted ourselves on the back because that in itself was a massive challenge. Things have moved on, and it's now a chronic disease, not an acute disease. And with any chronic disease, you need to support the more chronic issues. Having acute TTP can be absolutely soul-destroying, life-destroying for patients and their families, particularly if you're in intensive care, if you're surrounded by machines, you can't remember parts of the disease when you first came in and what happened. It's very, very frightening and often associated with flashbacks. And that may be quite soon after discharge, or it can be months or years later. And we have to develop the skills within our each our centres to have someone to support patients, because otherwise it's putting them on a back foot. They can't move on. They can't get better. They can't stop having flashbacks, nightmares, can't leave the house, won't go on holiday, won't, enjoy relationships with friends. All of those things are impacted. I mean, I need Joe, who works with us, also to be a testament to us, but I think the clinical psychologists we've had over the last 2 years have been magnificent, and even more than I would have anticipated, the benefit that they've shown and helped patients. But it is only the start. There is a lot more to do. But the whole anxiety, depression and PTSD thing has been somewhat improved. So it isn't a massive issue as it was, let's say, 5 years ago. It's not gone away, but it's dealt with quicker from inpatient stay, but also recurrently during outpatients. And they spend a lot of time with patients.
Sorry, do the patients go to them automatically, or does someone have to say, oh, you should go?
Oh, no, they're part of our clinic. Yeah. Yeah. Yeah, no.
To set up these multidisciplinary, these ideas, you have to have an awareness of these complications. And that's really what you're seeing in our USTMA. Our sites are organized because we have the expertise and the recognition. And they sort of build it from there. Once there's a recognition, just like Marie's, it's organically arranged that we have go-to people. They aren't there in the clinic with us. We know where they go for heart issues or neurologic issues or mood disorder issues. So this consortium is a way, and if you look at the care in Europe, is a bit different, that it's more centralized, especially for rare things. We're trying to force that here. In the US, you have the freedom to be treated, wherever you want to be. But care may not be uniform everywhere, and that's certainly the case here. You can get a lot of different answers in different places. This consortium is an effort to sort of standardize care across expert centers. And not everybody can go from California to see Senthil in Texas, but you can go somewhere close by in Utah and see Yazan, who's there. You can see our other people in whatever state it may be, Ohio or North Carolina. So I think that's the right approach. That's what's happening. And really our consortium here was built upon what I learned a lot from Paul and Marie and how it was done in Europe. It made a lot of sense. It was consistent practices. It was better research. It was quicker research. And that's really what we're doing. We're trying to be like our European colleagues over here.
But it takes time. I know you are, but it does take
I got my first gray hair last week. Yeah.
Huh?
I got my first gray hair last week.
It does. It took this, it all sounds very grand. He's sitting here up talking. It took years to get this to this position. Absolute years. Huh? Well, you haven't got any access to any drugs, so there's no centralization needed.
Great doctors there. We were talking last time about great doctors,
really
Katarina
good.
and Chris, but they just need the tools to
They
do it.
need
I think it'll
tools,
happen.
yeah.
It's a
And they're working hard on it. I just heard like a week or two ago, they're presenting some new data to I forget the governing body for medications. Yeah, I think that's the one.
Oh, for Kappa.
Yeah. So,
Let's not get
yeah, I was
political.
but in any case.
It'll be a different panel. We do have that time for a little bit of break or do some. Give people a chance to.
Stretch the legs.